Hi, my name is Neil Reddy, and I'm a medical oncologist at Duke University in Durham, North Carolina. Today I'd like to address the question of, should biomarkers be used to guide checkpoint inhibitor combination therapy in advanced non-small cell lung cancer? Programmed death receptor ligand 1, positivity on tumor cells, is a predictive biomarker for benefit to single-agent immune therapy with pembrolizumab, nivolumab, or atezolizumab in advanced non-small cell lung cancer. This slide shows positivity by immunohistochemistry in 3 different settings. On the left, a tumor with no PD-L1, in the middle, with low PD-L1 positivity, and on the right, with 100% of the tumor cells positive for PD-L1 staining. This is a forest plot from the Empower 150 study. In this study, patients with non-squamous lung cancer who received chemotherapy and bevacizumab with or without atezolizumab immune therapy. What it shows is that there was a benefit to the atezolizumab containing regimen whether PD-L1 was high, low, or negative. This is a slide for Keynote 189. It is another trial in non-squamous lung cancer. In this trial, patients received carboplatin, pemetrexed, with or without pembrolizumab in advanced non-small cell lung cancer. There was an improvement in survival for the overall population who received pembrolizumab, but there was also a benefit to the chemo-pembro combination whether the PD-L1 score was high, intermediate, or negative. Now I'd like to talk about Checkmate 227. This was a large randomized phase 3 trial. A major component of that trial was to compare nivolumab with low-dose ipilimumab 1 milligram per kilogram every 6 weeks to standard chemotherapy in advanced non-small cell lung cancer. This was for both non-squamous and squamous cell lung cancer. What this shows is that there was a significant improvement in overall survival for PD-L1 positive lung cancer and for PD-L1 negative cancer. The primary endpoint of this study was to look at overall survival in the PD-L1 positive population. So that is the group that received an FDA approval. However, if you simply look at benefit for the experimental regimen versus chemotherapy, the benefits seem similar regardless of whether the tumor is PD-L1 positive or PD-L1 negative. So now I'm going to talk about Checkmate 9LA. This is a relatively recently presented study at ASCO 2020. One of the major problems with immune therapy alone in treating advanced lung cancer is early progression. So in this study, 2 cycles of chemotherapy are given initially with nivolumab and low-dose ipilimumab to try to prevent rapid early progression of the cancer, but still give double immune therapy to try to get durable responses from the immune system. So overall, this was a positive trial. For the entire population, there was both a clinical and statistically significant improvement in outcome for overall survival compared to chemotherapy alone. This is the breakdown by PD-L1 score. On the left, you see the PD-L1 less than 1% of a tumor population with a hazard ratio of 0.62, and on the right, for the PD-L1 positive population, and the hazard ratio is 0.64. It's obvious for both of these curves, just looking at them, that the experimental regimen was superior to chemotherapy, and the benefit, whether PD-L1 negative or positive, looks similar. So what about total mutational burden? This is an investigational biomarker for using immune therapy in advanced cancers. There was recently an FDA approval to use pembrolizumab in any high TMB cancer. And what total mutational burden, the concept behind that is that if a tumor has a lot of mutations in its DNA, then it will produce a lot of abnormal proteins that are not wild type. And these abnormal proteins can be then recognized by the lymphocytes and thus increase the chances that there will be an immune reaction against the cancer. If you look at the right-hand side of this slide, you'll see a bunch of tumors that have high total mutational burdens, and these are largely cancers that tend to be really responsive to immune therapy. On the left-hand side are cancers that include many cancers that have a low total mutational burden and have a less chance of responding to immune therapy. So part of the Checkmate 227 trial that we discussed a little bit earlier looked at total mutational burden as an endpoint. So it looked at the 40% of lung cancer that has a total mutational burden of 10 mutations per megabase of DNA or higher, and looked at the comparative outcome for nivolumab and low-dose ipilimumab compared to chemotherapy. This met its primary endpoint and showed a markedly improved progression-free survival for nivolumab and ipilimumab in the high TMB group compared to chemotherapy, and also showed a high number of very durable responses. However, the FDA concluded that they did not want to approve based on progression-free survival alone, and they waited for the overall survival endpoint for this trial. So in conclusion, should biomarkers be used to guide checkpoint inhibitor combination therapy in advanced non-small cell lung cancer? Well, number one, when we look at chemotherapy plus IO combinations and nivolumab and low-dose ipilimumab regimens, the results were superior to chemotherapy for overall survival regardless of the tumor PD-L1 score. So chemotherapy plus atezolizumab or with pembrolizumab are appropriate choices for both PD-L1 positive and negative advanced lung cancer. The Checkmate 9LA regimen with nivolumab and low-dose ipilimumab with 2 cycles of chemotherapy is an appropriate choice for both PD-L1 positive and negative advanced lung cancer. And for Checkmate 227 with nivolumab and low-dose ipilimumab, there is overall superior survival compared to chemotherapy, regardless of whether the tumor was PD-L1 positive or PD-L1 negative. However, still test for PD-L1. In non-small cell lung cancers with a very high PD-L1 score, you can get very good survival outcome with a very favorable toxicity profile for pembrolizumab alone, and atezolizumab has also been recently approved in the high PD-L1 population. TMB as a biomarker is of great interest. It has not yet been approved as a biomarker in advanced lung cancer. The choice of combination IO therapy in advanced non-small cell lung cancer has become complex, and that's a good thing that there are so many choices. Factors to be considered include tumor burden, comorbidities, and patient preferences. Thank you very much for your attention.